Thank you for joining Cancer Support Community Atlanta for Frankly Speaking About Precision Medicine, facilitated by Dr. Bordoni with Georgia Cancer Specialists and moderated by Porscha Johnson with Northside Hospital Cancer Institute. Please visit our website, cscatlanta.org, for a complete list of live and recorded events. We invite you to sign up for our newsletter to stay connected to all future programs. Welcome everyone to today's program, Frankly Speaking About Precision Medicine. We're happy to have Dr. Bordoni back on this virtual platform. He has been very kind to do several of these programs for us, so we're happy to have him back, and of course happy to welcome Portia. So I am Katie Armsby, the Program Outreach Director with Cancer Support Community Atlanta. If this is your first time participating in a Cancer Support Community Atlanta program, we welcome you and invite you to visit our website, cscatlanta.org. There you can see the complete schedule of events that we have, including some virtual oncology programs. We have virtual support groups that meet. We have stress reduction programs like yoga, tai chi. We have a monthly nutrition seminar facilitated by an oncology dietitian with Northside Hospital Cancer Institute, and of course, education programs like these. So for a complete list of events, or if you ever want to watch a recording of a past event, please visit our website, cscatlanta.org. And I am excited to welcome today's program moderator, Porscha Johnson. Porscha Johnson practices as a medical oncology clinical pharmacy specialist at Northside Hospital of Atlanta, where she specializes in caring for medical oncology, hematology, and bone marrow transplant patient populations. She collaborates with a multidisciplinary team for treatment decisions and develops and maintains chemotherapy and supportive care protocols, policies, and procedures according to cutting-edge research within the field. Furthermore, Portia oversees and contributes to many hospital-wide and department initiatives, the development and delivery of educational material and presentation to all disciplines, as well as serves as an independent consultant for pharmacogenomics to ensure the exceptional care for all patients through implementation of precision medicine. So with that, welcome, Portia, and I'm going to pass it off to you to begin today's presentation.
Thank you, Katie. It is such an honor and a pleasure to be moderating with Dr. Bordoni, a beloved colleague of Northside Cancer Institute and a fellow team member of our cancer genomics team here at Northside Hospital Cancer Institute. So everyone, please welcome Dr. Bordoni. He is a board-certified medical oncologist with Georgia Cancer Specialists. Dr. Bordoni is the Director of Clinical Research and the leader of the Phase 1 Clinical Trials Program at Georgia Cancer Specialists, a member of Northside Hospital Cancer Institute, Lung Cancer Research Subcommittee, and the chair and founder of the annual Atlanta Precision Oncology Symposium. Dr. Bordoni is the founder and the past chair of the annual Atlanta Lung Cancer Symposium, and his clinical interests include lung cancer, head and neck cancer, and research. So at this time, I'll hand it back over to Dr. Bordoni to present his presentation entitled Frankly Speaking About Precision Medicine.
Thank you, Portia, for the kind introduction. Thank you, Katie, for the invitation. So this workshop will include an introduction, the definition of precision medicine, biomarker testing, using biomarkers to find best treatment for you, types of target therapies. We are going to touch on cost of biomarker testing and target therapies, and when genetic testing is for inheritable cancers can also help find the best treatment for you. So the slides that we are going to present, we are going to use for these presentations were medically reviewed in December 2021 by Sloan Mays, MSM, BSN. And as a disclosure, this program was developed by Cancer Support Community. They developed the content independently and have outside medical and psychological experts to review. CSC has final control over the content of the program. The program was also sponsored by Merck, AbbVie, and the Foundation Medicine. The presenter, meaning me, has been engaged by Cancer Support Community Atlanta for this presentation. So I don't have any financial relation or affiliation to disclose, and I'm not being paid by AbbVie, Foundation, or Merck. So let's try to define precision medicine. One definition is precision medicine is a new approach to the treatment of cancer, and is based on the concept of what is best way to treat this person's cancer, not this cancer, but this person's cancer. So another way to call precision medicine is personalized medicine. And by the way, even when the title of the discussion is precision medicine, they're going to concentrate, of course, on precision oncology, because this is about treatment of cancer. Another way to define precision medicine is, instead of the old definition or mantra about the treatment of cancer as one size fits all, the new concept of precision medicine, or according to precision medicine, is one size fits one. Many of you actually have experience probably receiving the same chemotherapy of the patient sitting next to your chair, receiving the chemotherapy for the same type of cancer. We didn't know probably back then that there were subtypes of cancer. And the definition actually was not by the organ of origin of the tumor, was not by what we see under the microscope, was because of the molecular makeup of the tumor. So one more time, the goal of precision medicine is a personal approach. The goal is to find the right treatment for the right patient. Now, the old ways to treat patients all the same, like for instance, lung, breast cancer, etc., with the same treatment, is part of the past. Instead, in precision medicine, we try to find your specific subtype of cancer by using biomarker testing that we are going to define in a second. So this is actually precision medicine and biomarker testing. Let's say actually the four people on the right side of the slide, they all of them actually young and older, they have actually the same cancer. And let's say actually that, as an example, they all have lung cancer. Are they all the same cancer? Well, maybe actually because of the location in the lung, because of the biopsy looking under the microscope, etc., they may all have the same cancer. But there are some details that are missing just by that observation. So the subtype of cancer is defined by biomarker testing. Now, how do you, or we find actually the markers? Well, here is a cell. The cell actually is, let's say, like a watermelon. And this watermelon actually have been cut a portion of a slice out, so you can see the inside. What is the inside? At the very center of the watermelon, or the cell, is actually that yellow and brownish portion that is the nucleus. In the nucleus actually is the DNA. The DNA actually is all the material coding for life. Every single function that has to do with be alive, for humans, for animals, for vegetables, etc., all of them actually has to do with the DNA that is packed in the nucleus of the cell. Now, on the surface of the cells, maybe some proteins, and they actually may perform activities like receptors. Those can be biomarkers. They can be the way to identify the difference between the patient on the left or the right in the upper portion of the right side of the slide. Now, those biomarkers can also be located in the inside of the cell. But in any case, by testing them, by looking those biomarkers, usually proteins, but could be actually other abnormalities in the DNA, the RNA, etc., we can distinguish patient A with A type of cancer, patient C, D, and B. So A, B, C, and D, they all have lung cancer, the same histology, they look the same under the microscope, but when you do molecular profiling of the tumor, the four of them are different. So the treatment is different, has to be different, and that is what precision oncology is by definition. Now, in order actually to obtain this biomarker profiling on testing, you have to obtain a sample. The sample of the cancer cells can be obtained by bodily fluids or tissue. Now, this is sent to the lab, and then the pathologist and Dr. Jennifer Bynum, one of the molecular pathologists here at Northside Cancer Institute, talk about how to analyze or test for those biomarkers a week ago. Now, this is actually the typical tissue biopsy. That is actually a sample of skin. As you can see, the upper portion of the skin or epidermis, the mid portion in pink or dermis, and the low portion that is fatty tissue or subcutaneous tissue. As you can see, this is like a punch biopsy. You take a cylinder, and this is actually a tissue biopsy. This is sent to the pathologist, and the pathologist can cut in very, very thin slides and can analyze by different type of procedures. Now, also, and like I told you before, they're looking for expression of DNA, RNA, or protein, expression or aberrations of them. Now, on the right side, actually, is another concept, how to obtain the sample. This is actually obtaining the sample from the blood. I don't know if you can see, actually, there is a blue spot in the lung, the left lung, that is the primary tumor, and a yellow spot in the liver, down there in the abdomen, and that is a metastasis, a spread of the cancer from the lung into the liver. What you can see going down the left upper extremity is an artery or maybe a vein. And you can see obtaining the blood sample from that vein. You can see actually those, they look like candies that are circulating in the blood. They are different colors, and they are pieces of RNA, or it could also be DNA, or it could also be protein. So this DNA, RNA, etc., they shed into the circulation from the tumors. We can actually take a blood sample, we can retrieve those, we can analyze them, and that analysis can give us the molecular profiling of the tumor in the lung or the lung and the liver, because even when one is derived from the other, the molecular profile may be different. Now, healthcare providers use different names when referring to biomarker testing. Comprehensive biomarker testing is one way, gene-based cancer testing, genetic testing of the cancer, and actually genetic testing have a different connotation. This is part actually of the testing we do in the context of genetic counseling, for instance. Cancer marker testing, next generation sequencing. Now, next generation sequencing, more than a biomarker testing, is a denomination of a comprehensive technique for the testing of biomarkers. Genomic profiling is one of the terms that I like the best. Mutation biomarker testing is another expression, but it's limited because we don't only these days look for mutations in DNA, for instance. We look beyond mutations for what we call aberrations, changes actually in the makeup in the DNA, like I told you before, RNA, and even proteins. Molecular profiling, tumor marker testing is a little bit different. The definition of tumor marker is some proteins can go in the circulation. They are made actually by tumors. They are specific of certain tumors, and they actually are used to follow the outcome of the tumor and the patient, of course, under the pressure of treatment. Mutation or molecular testing is another expression. Now, a biomarker is a sign of disease or abnormal function of the cancer cell, of the cell, that can be measured, as we said before, in your blood, in the tissue, or a body fluid. For instance, some of you actually may be very familiar with ascites, which is the accumulation of fluid in the abdominal or peritoneal cavity. We can also retrieve cancer cells from there. We can even retrieve from there pieces of DNA, RNA, etc., and we can analyze it from there. In cancer, biomarkers are often used to help choose the best treatment for you, and we will talk about that, and we will exemplify how to do that. So one more time, biomarkers can be proteins, genes, gene mutations, which is DNA, essentially, etc. Now, let's see actually with an example. This is a cartoon that is actually telling you about two things. One of them is the thread of DNA that is here in the center, I hope you can see, and it's in a kind of purple. So that is the DNA. There is actually the code. It's encoded different structures in the body like proteins. Proteins actually have multiple functions in the body. Proteins actually is the intermediary of life, are the ones actually that make process the structure of the body as well as the different processes, metabolic processes that allow life. Some of these, still on the left actually, some of these actually cartoons, in blue for instance, they are, the one in the back in orange for instance, they are proteins. They have been encoded by the DNA. Now, these proteins actually don't stay there in the nucleus next to the DNA. They migrate to other parts of the body. And this is actually what you can see on the right side or the right cartoon. Now, let me tell you actually what the cartoon is showing you. Here in the center, what you can see is the membrane of the cell, the membrane of the cancer cell. Whatever actually is up here is the extracellular portion of the cell. And you can see actually this portion of a receptor or a protein. This is actually the protein that was encoded up here in blue, that is now in the right position in the external portion of the cell. This is the internal portion of the cell. And this in purple is a portion of the internal or intracellular portion of the protein or the receptor. And this is actually where all the signals from the surface of the cell go through a pathway, an internal pathway with different checkpoints to the nucleus of the cell. In the nucleus, that activates the DNA, and the DNA actually tells the cell, grow, reproduce, metastasize, kill this patient, essentially. So what happened now is that in that purple portion of the internal or intracellular portion of the cell is where most of the mutations happen. Those mutations actually produce two things. One of them make the cell essentially live forever. So those cells become immortal. But second and most important, immortality in cells, normal cells, equals cancer. So cancer cells by definition are immortal. So that's what these mutations actually do, transform the cell from mortal with a limited number of hours or days or weeks of life to immortal, so they can grow without limit and develop into tumors, metastasize, and eventually kill the patient. Now, this new way to treat cancer is based on the subtype of cancer, like we said before, according to the molecular makeup of the cell. So there are cancer types, like for instance, you can hear about, adenocarcinoma or squamous cell carcinoma, to refer some cancer, for instance, of the lung, of the pancreas, of the colon, of the breast, of the maybe cervix, etc. So those are different cancer types. Now the cancer subtypes, the typification of the cancer has to do with a smaller molecules inside the cell. So when you say that actually up there, the newest way to treat cancer is based on the subtype of cancer, I would like to change that for molecular subtype of cancer. So you understand actually this is at the molecular level. It's not even what you can see under the microscope. Even the most powerful microscope is at the molecular level. Now let me introduce another concept. It's very interesting, and I think that is very interesting. These are lungs. So lung cancer comes from there. There is colon cancer. This is a pancreas cancer. This is the uterus. All these organs, they can actually produce tumors, or tumors can originate from all of these. And they may carry the same mutation, the same aberration in the DNA. Let's say KRAS mutation. Some of you actually may have heard about this because it's pretty common. It's one of the most common in lung cancer. It's very common in pancreas cancer, pretty common in colon, and to some extent it's pretty common now we are finding in endometrial cancer in the uterus. Now, all of them, even when these are different cancers coming from different organs, all of them can be treated with the same treatment. Why? Because the molecular defect that triggers the development of the cancer and the growth, development, or metastasis of the cancer is the same. It's the molecular alteration inside the cell inside the tumor, maybe on the surface or the inside of the cell in the cytoplasm. To the point, for instance, in some cancer centers, there are clinics. There are not lung cancer clinic, pancreas cancer clinic, colon cancer clinic, etc. They are KRAS mutation clinics. And patients with lung, pancreas, colon, endometrial cancer may come to the same clinic to be treated by a specialized medical oncology in KRAS mutation, not in lung, breast, colon, etc. So it's a relatively new concept, but to understand actually that some mutations are across different types of cancer, regardless of the organ where the cancer comes from. Oh, sorry. So biomarker testing is used to determine the subtype of cancer, can be an important part of the cancer diagnosis, provides information about the cancer you have beyond the type and stage. Now, it can be used actually to look for early signs of how well your body responds to a specific treatment. This is a very interesting concept because now we are beyond the diagnosis, we are beyond the identification of the subtype of cancer. The patient is already on targeted therapy or immunotherapy or hormone therapy that are all under the definition of targeted therapy. But let's go back to the concept of the liquid biopsy. So we take a blood sample, we identify the DNA shed by the tumors in the circulation. But we can do this biopsy many times during the course of the cancer, during the treatment. And then actually you can see, so you can see something like this. Let's say actually that in the very first portion of this cartoon, in this portion is the tumor. The tumor is an early stage, and there are two different types of DNA that is shedding in the circulation, and you can retrieve them by a simple blood sample. The light blue is one type, the dark blue is a different one. Here actually almost you cannot see the DNA in the circulation anymore. Why? Because the patient has surgery. But you can continue doing blood tests, you continue checking in the circulation by a simple blood sample, and all of a sudden that DNA mutation start going up again. And again, both of them, the ones that were in the original tumor, the light blue and the dark blue. What happened there? The tumor is coming back, unfortunately, even after surgery. This is actually when the tumor, we call it, suffer recurrence, came back. So at this point, actually, many times, we call actually now a molecular recurrence of the tumor because you cannot see the tumor by a CT scan or any other MRI, etc. But you can see it, literally see it in the circulation by the DNA that is accumulating there. Eventually, the patient may develop symptoms, and the patient actually may have tumors that you can see in the CT scan, etc. So based on this DNA, that may be identical to us here or a little bit different sometimes, you start treatment. And you can see one more time, the DNA in the circulation goes down to the point you almost cannot detect it anymore. Why? Because the patient may be almost in remission. But unfortunately, after maybe 6 months, a year, 2 years, the cancer starts growing back. But this time there is an addition. In addition to the light blue and the dark blue, there is this black. This black is a different type of DNA that is being shed from the tumors. Why? Because there is addition of a new mutation or a new molecular aberration. What is that? That is actually what we call a resistant mutation. Under the pressure of the treatment, in this portion of the life of the tumor, under the pressure, the tumor is trying to escape our treatment. Tumors are very smart. They develop other molecular mechanisms to get away from the treatment that we are introducing into the cancer cell. So that's what it does. It produces this other molecular aberration, gets away from the pressure of the target therapy, but we can change the treatment We can introduce another target agent or chemotherapy, etc. And one more time. If we are lucky, we might control for a while the tumor until another molecular event happens that is defined by this red color. Now, we can also use molecular testing or biomarkers to judge how well your body could respond to a specific treatment. That is what we call prognostic value of those biomarkers. And also down there to understand the molecular makeup of your cancer and how it changes over time. I think that that is exactly what I was trying to relate to you in the graph above in the different tones of blue. Now, also, biomarker testing can be used to get a sense of how quickly your cancer is growing or spreading, and also to make a prediction about your risk of developing cancer. Now, this is not exactly how the biomarkers are used for precision oncology. That is the topic today. This is more about genetic counseling or genetic testing. Now, these are actually some of the biomarkers. Some you are very familiar with probably, like in breast cancer, ER stands for estrogen receptor, PR, progesterone receptor, and then BRCA1 and 2, BRCA1 and BRCA2. And in the middle, HER2, which is a protein expressed on the surface of breast cancer cells, and they actually define a subtype of breast cancer more aggressive than the ER/PR positive. ER/PR positive usually are HER2 negative and vice versa. In lung, common biomarkers are EGFR, ALK, ROS, or also called ROS1, RET, BRAF, MET, etc. PD-L1 is a protein expressed on the surface of the cell and is used to see which patient we can prognosticate that will respond to immunotherapy. Others apply to colorectal, gastrointestinal stromal tumors, that is a type of sarcoma, and then liquid tumors like leukemia, ovarian, even brain tumors, and other solid tumors. So, there are some questions like, does my type of cancer have biomarker test? If yes, can I get tested? The answer actually to this practical question is maybe, but we don't know. And even more, you come in my office and you are maybe a, ovarian cancer patient. These days, actually, ovarian cancer, in the definition of the subtype at the treatment, is also becoming very molecular. And if you ask me this question the first time you come in my office, my answer will be, I don't know. But you know what? With the biopsy we took from you, we sent to the pathologist, they are processing the tissue, and they are going to give us their answer, and then I'll share the answer with you. Or, at the same time, the pathologist may be doing that, just in case, if they run out of tissue to test for those biomarkers, I would like to draw a blood sample, 10 cc's of blood, and I'm going to send out to the same lab as a liquid biopsy, so we can answer the same way your question. What biomarkers will you test for? This is a very interesting question. Until recently, we were testing maybe 6, 7 years ago, one at a time. Now we don't do that anymore. We test actually for 20, 25, 40, 60, even hundreds. Why? Because some of them are common, and we want to look for them because the chances are pretty high that you may carry that mutation, and I can treat you with a specific targeted therapy. But some others are rare, but still maybe some treatment FDA approved or experimental that I can offer you that may be very promising. And I don't want to limit you from that treatment option. And finally, for discovery, maybe actually there is some genomic abnormalities that we were not aware of in your ovarian cancer. And maybe we can check actually with the database, and we see that there were 3 ovarian cancers in the last 5 years with the same molecular aberration. So we can conclude that this may be a new subtype of ovarian cancer that needs to be treated in a specific fashion, excuse me, with a specific targeted therapy. So that is discovery. What will biomarker test result tell us? Again, the subtype of cancer and what treatment is the best for you in particular. Now, let me tell you actually that this issue is becoming a little bit more complex every day. This is actually, a demonstration of lung cancer, non-small cell lung cancer metastatic stage. And you can see each of one different colors. The slide of a cake is a cake graph. You can see actually that it's a different type of mutation. They have been already identified. So I would like to know, if you are a lung cancer, come to my office for the first time, in what subcategory or type are you? Which color do you belong to? So that's what, again, the tissue biomarker testing or profiling or the liquid biopsy does. In the past, only about 10–15% of my lung cancer patients, non-small cell lung cancer, mainly adenocarcinoma, were subtypes. Now, 50 or more than 50% can be subtypes. So all of them are amenable of a specific personalized treatment with targeted therapy. So if your cancer has a specific biomarkers, your doctor may decide to use a therapy called targeted therapy. Now, how to visualize? I'm a very visual person. I hope you are too. What target therapy is? I believe actually the best or one of the best ways to visualize it is like the lock and the key. If you have the right key, that is the targeted drug, you can actually get into the lock and you can open the lock or the door and you can get into the house if there is a door and there is a specific lock to enter the house. Now, I think that it's a little bit more difficult to identify the different components on the left in this right cartoon. Well, here in yellow, crossing actually from left to right, is the cell membrane. This is actually the cancer cell. This is the membrane that limits the cell. This is the outside, this is the inside. This is the same protein in the extracellular, outside the cell, intracellular domain, and here in between. Here actually this protein, that is also a receptor, is anchored, is stuck to the cell. In this intracellular portion of this protein, there is a growth, and this growth changes the conformation, the 3D conformation. And that actually change if the cell is a normal cell or if it is a cancer cell, and this portion of the protein suffers a specific mutation. So we now know about the shape of the growth, and we are developing drugs like this in purple that will just exactly fit in the growth. If you can fit a drug in that growth, this is a targeted agent or targeted growth, you can actually block the signal coming from the outside of the cell, going all the way to the inside, and then the nucleus to tell the cell, grow, metastasize, and kill the patient. So that is the key, is the targeted agent in purple and the lock, that is actually that big protein anchor in the membrane of the cancer cell. So target therapies are a new kind of cancer treatment, and the target therapy target a specific cancer subtype. They are only likely to work in those specific subtypes. Now, cancer subtypes can be identified by the presence or absence of the biomarker. Doctors use the biomarker to test for information to help match targeted therapy drugs to the specific cancer subtype. Now, there is no guarantee that the targeted therapy will work. Why? Let me go back for a second to the key and the lock. So here actually is the key. We put the key inside the lock and it fits very well. But you know by experience, there are some keys that fit in the lock in your house but don't open the door. Why they don't open the door? Because they are very similar to other keys, to the key that is the right one. So some targeted agents it looks like they are going to work, it goes into the growth perfectly, but they don't deactivate the system or block the signal. So again, one more time, using the right target agent is not a guarantee that it's going to work. Another reason is because the target agent is the right one, the growth is the right one. In other words, the lock and the key are the same and they match, but maybe the pathway that goes from the membrane of the cell into the nucleus, that is the one actually tells the cell to stop growing, to stop metastasizing, is not functional. And if they are not working, the target agent doesn't work, because without the pathway that is functional, there is no function. So target therapy actually may work by finding and tagging cancer cells, destroying cancer cells directly, cutting off the blood circulation of the tumor. Now, this one actually is tricky, because for this one, we have the targeted agent. There is an antibody or monoclonal antibody, but we don't know what the target is. We think what the target is, but we are not 100% sure. In any way, it works, so we continue using it. Cutting off the hormone supply to the tumor is mainly applied to breast and prostate cancer, and taking the brakes off the immune system. This taking the brakes off the immune system is the basis of a new form of treatment, or a new modality that is called immune therapy or immunotherapy. And some of you may be very familiar, because now it's a standard of care for the treatment as a single agent or single modality, or in combination with chemotherapy for different types of cancer. Now, this is actually one of the explanations how target therapy works. The target therapy sticks to the surface of the cell and acts as a tag. And this has to do mainly with the immune system. So let me show you this cartoon. Now, I'm going to pretend, and you please follow me, that the one in the low portion of the cartoon, even when it's part of the immune system, is an immune cell. Let's actually pretend there is a cancer cell. The cell actually in the superior, the upper portion of the cartoon, in green, deep green, that is the immune cell. You can see actually that there is some kind of a connection between the immune cell and the cancer cell. You can see there actually in blue, coming down there from the surface of the immune cell, and in orange from the cancer cell. This is the way the cancer cell communicates to the immune system. And the reason actually does is to tell the immune system, go sleep, don't attack me, don't work against me. Unfortunately, when the cancer cell sends that signal to the immune system, the immune cell obeys. So the immune system actually may go to sleep and allow the cancer cell, first of all, to develop, to be able to even develop one single cell in the body, and then to continue growing to develop into a tumor in one place or in many places when the cancer develops metastasis. So we need to cut that message from the cancer to the immune cell. How do we cut the message? So what we do actually is we develop these guys there, these Y-shaped monoclonal antibodies. They go against this blue receptor that is called CTLA-4 here, but it's just one example. If this actually tags or binds very strongly to this blue receptor on the immune cell, the signal from the tumor cell doesn't get to the immune cell. And then the immune cell is free to develop, grow, becomes active, and eventually attack the cancer cell and kill the cancer cell. That is so simple, but it's so smart how we can neutralize the communication between the cancer and the immune cell. We can activate the immune system, and that is the principle of immunotherapy as a new form of cancer treatment. Some targeted therapies can stick to targets on the surface and kill those cells directly. I will exemplify this later with another cartoon. Some targeted therapies stop tumor growth by cutting the blood supply. So how that happens? And I unfortunately don't have a cartoon, but I think that I can explain it to you. Let's say my fist is the tumor, and let's say actually my arm is an artery. That artery is going into the tumor, and it's bringing the blood supply and food, nutrients to the tumor, so the tumor can grow. Now, the arterial circulation outside the tumor is different than the arteries inside the tumor. They have a different biology, different receptors, different biomarkers. We take advantage of that to develop a specific monoclonal antibodies, anti-angiogenic, to target the cells in the arteries in the tumor, inside the tumor, not outside the tumor circulation. By doing so, we cut the circulation, the cells don't have any nutrients and die. But you don't cut the circulation of the normal cells in the body. So it's another smart way that we are using now for many years. Even more, actually, we are using it less and less because there are some other ways to do the same in a more efficient way. Now, sometimes hormones are the fuel for cancers to grow, and we can cut actually by occupying the receptor to the hormones. So here is the receptor, this is the hormone coming inside the growth, and it's telling the cell, again, to grow and to metastasize. This could be the estrogen receptor in the breast cancer cell, or can be the androgen receptor in the prostate cancer cell. This is an anti-hormone against estrogen or androgen. Go in there, blocks the signal, and the cell dies because they don't have the fuel to feed the cancer cell. Now, this is about the immune system, and it works actually two ways. I explained to you one way, how to activate the immune system. Now, there is a problem. If you activate the immune system doesn't have brakes anymore. It's like you are driving a car 80 miles an hour on the highway, and now all the way I leave you without the brakes. So you are going to crash, and that's what may happen with the immune system. The problem is that when the immune system crashes, it crashes against your normal cells. So forget about the cancer cells. They already attacked them, destroyed them, but now it continues the next step. Start destroying your normal body cells. So we need actually to obtain a balance between one and the other, between enhancing the immune system, but giving the immune cells also the break to stop attacking the normal cells in the body. We are doing that to some extent, but unfortunately, not 100% well. And because of that, there are some side effects from the immune treatment or immunotherapy that we are going to talk about later. Well, later is actually now. These are some of the common side effects. Rash. What happened actually, some of the same receptors are in the skin, in a portion of the skin, the cells of the skin. And because that rash can happen when you are exposed to both targeted therapy, like the oral agent, but also actually immunotherapy given IV. Immunotherapy so far, experimentally, is only given IV. So again, one more time, rash happens, usually it's mild, but it can be very severe, and even more, can kill the patient in very, very few cases of immunotherapy. A simple dry skin, not even a rash, is even more common, with or without itching. Fatigue is very common, but usually less than the fatigue you as a cancer patient experience with chemotherapy. A flu-like reaction can happen, but diarrhea is more common. I would say that skin, rash, diarrhea, colon, lungs, shortening of breath, dropping the oxygen, etc., are more common. And also dysfunction of the thyroid gland. Those are pretty common, about 8% or less. For you, actually, 8% may be a very low number because with chemotherapy, we are used to 20, 30, 50, 80%. So the numbers are much smaller with immunotherapy, but it can be present. Usually are very mild, but again, can be present. Sometimes target therapy may be used in combination with chemotherapy, radiation, immunotherapy, or hormone therapy. Well, let me actually dissect this statement. Target therapy, in general, is used as a single agent. When combined with radiation therapy, may be too toxic, at least for now. Maybe later on, we will learn how to use them together. It can be used with chemotherapy, but again, except in a few patients, when you use them together, it's too toxic, but also it doesn't work as well. But if you use or the target or the chemotherapy as a single modality. Immunotherapy and chemotherapy, yes, they go well together. And then the hormone therapy, of course, can be used as a single modality or in combination, for instance, with chemotherapy. Now, this is one of the examples that I wanted to give you. Many of you are familiar with HER2 positive cancer, breast cancer. So HER2 actually is a biomarker that defines 20% of the breast cancer patients. There is a protein that is sticking out. Let's say this is the cancer cell, and it's a protein sticking out on the surface of the cell. Now we are changing the denomination. So if you read some, brochure about HER2, it may not say HER2 anymore or HER2 between parentheses. It may actually be called EBV2 or ERBV2. In any case, it's the same thing. So HER2 actually defines 20% of the breast cancer, and those are a form more aggressive of breast cancer than the most common, mainly in the elderly, ER/PR positive breast cancer. Now, there is an antibody, there is an anti-HER2 that it was developed, neutralizes that protein, and essentially changes the biology of the breast cancer. That cancer actually becomes, under the treatment of the HER2 or anti-HER2 monoclonal antibody, a good prognosis equivalent to the ER/PR breast cancer. Down there you see there are now 5 types of different drugs available to target HER2. Every time actually more efficient than the prior generation. And this is the cartoon. One more time, here this time in gray, which is a better color for the cell protein, for the cell membrane probably, is the cell membrane. Out here, sorry. So out there, where you can see actually the red X, is the portion outside the cell. There is actually part of the protein that, let me see if I can show you with the arrow up here. This actually in blue and yellow is the HER2. It's a protein, but it's also a receptor. And on the left side, you can see actually in yellow, again, the Y shape is a monoclonal antibody. It's called Herceptin. That was the first generation of antibody, binds to the HER2 on the surface of the cell, neutralizes or blocks the function, and because of that, blocks the HER2 positive breast cancer cell and directly kill the cell. So what are the name of target therapy drugs that I could or will receive? There are so many names. Maybe actually during the question and answer session, we can be more specific. Where and how will I receive my treatment? Target therapy is immunotherapy or anti-HER2 or anti-angiogenesis in the office. Unfortunately, they are IV. You have to spend time in the office. Is there a pill? Of course, at home. You come in the office once in a while, at the beginning in 1 or 2 weeks, then every month, then maybe every 3-4 months or so. So in different places, according to the type of target therapy. How often will I get the treatment? It can be if it is immunotherapy, anti-angiogenesis, etc., every 2, every 3, every 4 weeks or less. IV in the office. And if it is a pill, every day, sometimes not every day of the month, maybe 2 out of 3 weeks or 3 out of 4 weeks. What side effects should I expect? How will we manage them? So some of the side effects we mentioned, there are more than that. And in general, actually, we train the patient to identify the side effects and call us as soon as possible. Our nurses, nurse practitioners, and of course, the providers, we are all trained, to manage these side effects, these adverse events. So you call, even overnight, during the weekend, we will help you to manage the side effects. Will I receive target therapy alone or in combination? Like I told you, it depends on the type of cancer. It depends on the FDA approval. And remember, the FDA approves whatever actually we have the experience about, but also what is best for you. How long will I need to receive this treatment? It all depends. One more time. In general, target therapy, including immunotherapy, hormone treatment, etc., are not like chemotherapy, but we give you 4 or maybe 6 cycles and then we stop, or we switch to maintenance chemotherapy. That is a milder form of chemotherapy. With this, we continue for many, many months or even years, as long as the cancer doesn't grow. So remember, actually, there is a concept that is chronic disease that applies to conditions like diabetes or hypertension. That is one of the goals of cancer with target therapy or immunotherapy. Make the cancer become or transform cancer into a chronic disease like diabetes or hypertension. For how long do you take anti-hypertensive or diabetes medication? For years, for decades. Hopefully the same will be with cancer. We won't be able to cure cancer, but you will live with cancer, hopefully without symptoms, with a few side effects from the chronic treatment. So this target therapy benefits some, but not all. Why? Because again, not all have the biomarkers. If you don't have the biomarker, it's like not having the key. You have the lock, it's not enough. Not all subtypes have a target therapy. Even if your tumor has a biomarker that matches with the target therapy, it doesn't guarantee the therapy will work. We already explained that. And the target therapy probably is not a cure. Maybe becoming a cure, however. We have many examples now. Patients after being on a pill many years, sometimes 7, 8, 10 years, like in chronic leukemia, we stop the treatment with a pill. And about 25% of the patients, after years without taking the pill, the cancer doesn't come back. That may be the definition of cure, a new definition of cancer cure that applies to these target agents or targeted therapy. Biomarker testing can be expensive. Fortunately, most of the insurance companies, payers, pay for them. Otherwise, there are, I would say, cancer biomarker or biomarker laboratories that have foundations, and they are very good in helping patients pay for the cost. Some clinical trials will test your biomarker at no cost, but of course, you have to participate of the clinical trial, and some patient advocacy groups may help you also. Now, many target therapies are complex drugs, can be very expensive. However, one more time, we look for the coverage of your insurance before actually we start the treatment, and we try to help you in different ways by tapping into different foundations. One of them, as you can see there, for more information is www.cancersupportcommunity.org. This is actually the second part of the talk, but we are going to start the talk there.
All right. Thank you so much, Dr. Bordoni, for such a lovely presentation. I feel like this was very educational for me, and I'm sure for the audience. We have a lot of questions that your presentation has garnered. So at this time, are you willing to entertain some questions?
If you have any question, I'm ready.
All right. So the first question, I guess we can start off is, what are your thoughts about single gene versus whole genome sequencing?
So that is a very good question. Single gene sequencing is something actually I mentioned before we used many years ago when EGFR, for instance, for lung cancer became actually the only one that we were aware of and had a targeted agent to treat. Then we were just checking on that. Over the years, actually, ROS1, ALK became available, and we started checking for about 4 different genes. Then eventually, and now, at least we check for 9 different gene aberrations or mutations in lung cancer. In reality, we do comprehensive gene profiling. So it's much more than 9, but in any case, 9 are the minimum that we check for. Now, in the past also we were sequentially checking for them. We checked EGFR. When we received the report, if it was negative, we went to ALK. If it was negative, ROS1, etc. It takes too long. So now actually we take a sample, and with a different chip in the machine doing the profiling, we can get the report in 7 to 14 days for hundreds of genes.
Very, very nice. So I guess at what point in time should the biomarker testing be even redone? So if they get it initially or once they progress, at what time should it be redone?
That's a very good question. So one of the concepts actually that is experimental is you check actually that profile periodically, let's say every 6 months, even if the patient is doing well. And you start checking for mutations that may not clinically express. The patient doesn't have new symptoms, the CT scan doesn't show any progression of disease, but those resistant mutations that I defined before, those actually may be there. We did actually a clinical trial several years ago, and we found that women that are, they are more brave than men, they actually were willing actually to have lung biopsies every week. So they underwent actually bronchoscopies, and we took tissue biopsies. Back then, we didn't have the liquid biopsies. And we found that some of the resistant mutations were present a week, 10 days after the initial treatment. Those patients did well for months and months, or even a year or more than a year on that specific therapy. However, we may not continue the treatment for that long if we see that the resistant mutations are already emerging. So right now, answering your question, we only do actually or reprofile the patient if there is any evidence of progression of the cancer. But the concept that is experimental is maybe, instead of waiting until the cancer progresses on the CT scan, go by molecular progression and introduce a new treatment. This is the same as if the blood sugar is not good enough on 1 or 2 different pills, you add another pill or replace the prior with a new pill, and you continue a good control of the diabetes. The same actually eventually will become cancer.
So with that being said, it's safe to assume that if a patient progresses, that they should not resume the same immunotherapy or targeted therapy that they were on before, correct?
That is another excellent question, and the answer is may or may not. So it depends actually on the molecular profiling. If the same, what we call driving event, is the same mutation that developed the cancer and drove the cancer into growing and metastasizing is still present, we may need to continue using the same targeted agent. But we may be able, with the new molecular profiling, to identify a new DNA aberration that we can target with a second pill or some other agent, IV or whatever. And then by adding a second agent, we may be able actually to block the 2 driving events. This is like a bus. A bus actually we are used has only 1 wheel and only 1 driver. But in cancer, sometimes the bus may have 2 wheels or at least more than 1 wheel, maybe a couple of drivers. And we have to block the 2 of them. We have to take them out, both drivers. for the bus to stop or for the cancer to stop growing.
Very nice. I love your the way that you put things. I think that's very relatable for our community participants as well, and just even for me to understand. So thank you for putting it so frankly. We do have a couple of specific case questions for you. So one of our participants said that they were diagnosed with stage 2 primary non-small cell lung cancer with an EGFR exon 21 mutation. They had a lobectomy of the right upper chest. They went through chemo, and Tagrisso was recommended by the oncologist doctor for 2 years. She said that it's considered a miracle therapy, especially for early stages, but what are the benefits versus risks, especially with the interstitial lung disease side effects that concerns them?
The benefit is huge. By the way, not everybody actually needs after surgery, successful surgery, to receive chemotherapy before going on the pill. But some patients, according to the stage, according actually how big the tumor and the lymph nodes are, or how many positive lymph nodes, may need chemotherapy and then go on the pill. So the benefits are so huge that when the clinical trial called ADAURA was published, the benefit was so huge that we couldn't believe, because in cancer treatment and lung cancer treatment in particular, we were not used at all of that kind of benefit. I'm talking actually a benefit in about 87–90% of the patients. The benefit actually for chemotherapy, remember, max maybe 40%, maybe 50%, according how you, by which parameters you measure response or benefit. So we are talking huge benefits in the adjuvant setting. Very few patients develop the interstitial lung disease, and many of them, the grade is 1 or 2. So the patient actually holding the treatment for a while, the symptoms improve with or without steroids for a short period of time, a few weeks, and many of those patients can be re-challenged with the same agent successfully.
Thank you for that answer. Our next case question says that genetic counseling showed me as an ATM positive gene. Is that most likely why I had germ cell ovarian, breast cancer, BRCA1 and 2 negative, and non-small cell lung cancer, EGFR exon 21?
I think that if the patient actually had EGFR positive, Portia, is that what you say? EGFR positive or negative?
EGFR positive with the exon 21 mutation. So
I think that there are two different elements. On one side, actually, the ATM, unfortunately, or BRCA, explains actually that that person, not patient, person, from birth had actually some kind of soft point in the DNA. The DNA actually breaks down easier than other persons without actually that condition. So you have a predisposition for the DNA breaking down, and that predisposition predisposes you for the development of some cancers like ovarian, breast, etc. Now, the EGFR mutation is not a germ cell mutation. You were not born with that mutation, most likely. Very few that account for lung cancer familial disease may have a germline EGFR mutation. But most likely that is a mutation that happened because of some kind of environmental pressure. So one is not connected with the other as far as I know at this point. Maybe there is some connection that I don't know, or we will learn in the future.
Well, hopefully answered their question. I hope that they're on the line listening. But we do have one more question, and it says, have you found any therapies for precision oncology that work for multiple myeloma cancers?
Yeah, multiple myeloma is a little bit different animal, but yes, we are using actually more than one. Monoclonal antibodies now are extremely common, And I think that, Portia, you can answer this question probably better than me, but because you are with the BMT group and liquid tumors, but yes, monoclonals are forms of targeted therapy, and we define actually multiple myeloma according to the molecular profiling from the prognostic, but also from the therapeutic standpoint. So the answer is yes. My niche, my expertise is more actually in solid tumors, in particular lung cancer, phase 1, etc. So I'm not that familiar with multiple myeloma, but I know enough to tell you yes.
Now, I will say, I feel like there's a different gene that is being found every single day. And of course, with research undergoing, there are so many landmark trials that are underway. And I definitely feel like if not now, soon, there will be multiple treatment options for those type of patients. But we are going to wrap up if we don't have any more questions. And I'm going to hand this back over to Katie to close us out. And thank you so much, Dr. Bordoni, for your wonderful lecture. And I hope that we all learned something. Thank you.
Thank you, Portia, and thank you everybody for coming to the meeting.
Thank you, Portia, and thank you, Dr. Bordoni, for both being so generous with your time and expertise today. Thank you, everybody, for entering such great questions. I do want to encourage everyone to visit our website, cscatlanta.org, where you can find a recording of today's event. So please feel free to share that link with anybody who wasn't able to join us live. And while you're there, please check out all of our virtual oncology programs. We have some great nutrition seminars, cooking demos, and stress reduction classes. So thank you everybody for joining us, and we hope to see you soon. Take care. Thank you for joining Cancer Support Community Atlanta for this program. If you're interested in other live or recorded programs, please visit the online program tab of our website, cscatlanta.org, or follow us on Facebook. We'll be sharing additional information on upcoming programs.